Welcome everybody to Scale Neonatology Virtual Clinical Grand Round. I'm Dr. Kathy, Consultant Neonatologist in Bali Regional Referral Hospital, and you're almost welcome to join us today. We have what I think is a really exciting topic today to discuss, which is about retinopathy of prematurity. We've just celebrated World Prematurity Day, and indeed November is World Prematurity Month. So unfortunately, I'm not wearing purple today, but I have been wearing a lot of purple, but hopefully some of you are still wearing purple. But I think as we move forward, especially here in Uganda, we're really focusing on the survival of our babies. But what we're seeing in more and more hospitals, both in Kampala and the regional referral hospitals, is that more of these babies of 28, 27, 26, and in some instances even younger, are surviving. And what we really want to see is these babies surviving disability free. And at the moment, we don't have a lot of data on the incidence of retinopathy of prematurity or the severity of what we see here in Uganda. And I think it's important that we begin to address this so that we are saving babies who are able to thrive and be functional in our society. So we have a great lineup today. For those of you who haven't been before, Scale Neonatology is a collaboration between NHS England and Ministry of Health here in Uganda. And specifically, our centres of excellence here are twinned with Bradford Teaching Hospital, and then also West Yorkshire, and also Leeds Teaching Hospitals. And all of this is brought together with the Uganda-UK Health Alliance.
Thank you so much. Just like I've been introduced, I'm Dr. Anita Muhumuza. I'm a pediatrician and someone who has been very passionate about newborns and been working with newborns for about 10 years in the neonatal unit, and very happy to be here. So I'll be beginning the presentation with a case summary, and Dr. Iddi will pick on from the case. So I can go to the first slide. So the objectives of our presentation or discussion today is, number one, we want to highlight a case of stage 3 retinopathy of prematurity who was treated with an intravitreal bevacizumab and regressed successfully. So we had a baby who got stage 3 ROP, was treated and regressed. And we also we hope we can understand the importance of early and regular ROP screening, and also to highlight the role of timely treatment and follow-up, because we've been having many challenges of where we lose follow-up, and some of these babies actually show up when they are already stage 5, when you already cannot treat. So these are our main objectives for today's discussion. So as part of the history for this baby, so the maternal history, this was a baby born to a 26-year-old mom, and this was her first baby. So she had an emergency C-section that was done due to premature rupture of membranes, and that was at 29 weeks of gestation. So we had the baby delivered with a birth weight of 1,400 grams, and the baby was given initial care, received CPAP in theater, and then was admitted to the neonatal unit. Was admitted to the NICU and managed for distress alongside other conditions that we shall see. So while in the NICU, like I said, this baby was in the NICU for about a month. So while in the NICU, some tests were done. So mainly, usually we do routine investigations. We do like CBCs for these babies. Usually after about 24 to 48 hours of life, we do a CBC, we do a CRP, and we do a blood culture sometimes when there is known risk for early onset or when there's any clinical evidence of late onset sepsis. So for this baby, we had a CBC, sorry, that was CBC, not CBS, the CBC, which was essentially normal. And because the baby was on oxygen for quite some time, beyond 3 weeks, so a cardiac echo was also done to rule out any cardiac lesion, but the cardiac echo was normal. And we did a cranial ultrasound. So in our NICU, we do cranial ultrasound scans for the babies, usually between the 3rd and the 7th day of life. And for some very high-risk babies or those who had a bleed, we repeat at day 28 or before they are discharged. So this baby had a cranial ultrasound scan done, and this was in the 1st week of life. This was the day 7 scan. And this baby had grade 2 intraventricular hemorrhage according to the cranial scan. Next. So in terms of management for this baby, so like I highlighted earlier, this baby was in the NICU for a total of 6 weeks. And for the time that the baby was in the NICU, the baby was actually on oxygen for quite some time. The baby was receiving oxygen for about 30 days. Was initially on CPAP, the continuous positive air pressure. Baby was on CPAP for the first 2 weeks. Later was weaned off to free flow oxygen. But unfortunately, at that time, the baby was receiving unblended oxygen. Because of fewer oxygen blenders, we are not able to blend for each and every baby at the moment. So some of the babies do receive unblended oxygen. So this baby was on unblended oxygen, and the total time on oxygen was actually for 30 days before the baby was finally weaned, successfully weaned. So like I said earlier, this baby received IV antibiotics because of the history of pre-prom from the mom. Usually we give them prophylactic antibiotics. So baby also received prophylactic antibiotics for the first week of life. So we managed for distress, usually CPAP, like I said. Baby received caffeine, but this baby did not receive surfactant because it was not indicated. The baby had distress, but it was not severe. So usually we use the SAS score to assess the need for surfactant in the babies, especially since we don't have blenders for all of them. We use the SAS score as a proxy, and for babies who have a SAS score of 6 and above, then we give them surfactant. When they have moderate severe distress, we consider surfactant. And usually we aim to give it at least within about 6 to 24 hours of life. So this baby was relatively, the distress was not severe, so did not receive surfactant, was on CPAP, caffeine, and the rest. We managed for neonatal sepsis because it's a big challenge we have in the unit, especially for all these long stay preterms. Usually by the time they reach the 3rd or 4th week, most of them get also late onset sepsis. So this baby also received a second course of antibiotics later during their stay for late onset sepsis. Baby was breastfeeding exclusively, was on express breast milk initially, was actually on express breast milk because by the time they left is when the baby was learning how to suckle, so we're still receiving express breast milk. The baby had a blood transfusion, had blood transfusions twice for anemia of prematurity. The first HB was the hemoglobin, which was done, that was at around 4 weeks of life. Baby had HB of about 6.5. And because the baby was still on oxygen, the baby was received a transfusion with packed red blood cells. And when the repeat HB was done, that's around the 5th week, because it had only risen to about 7, and baby was still requiring oxygen, so a second transfusion was given. So those are the 2 points at which the baby was transfused, because we have a protocol that we use, and for babies who actually still require oxygen, when they require free flow oxygen, so we always make sure at least their HB is 10 and above. So that's why the baby received transfusions. I think in a nutshell, this is the summary of a quick summary of the baby, of how we journeyed through this preterm until the 6th week when the baby was actually finally discharged. I think Dr. Iddi will pick on from here to talk about the ROP screening that was done when the baby was still on the ward. Thank you.
Now sharing the management, but before going into the glimpses of how ROP appears, I just want to show what exactly we do during the ROP screening in Mulago Women Hospital and how ROP screening is done. And this is me doing indirect ophthalmoscopy, which I abbreviated as IO, and the Volkin viewfinder's camera. And so in this picture, which I'm zooming in, hope it's now shown as zoom in, this is the indirect ophthalmoscope, which is one on the head. And then there is a 20D lens, and also at times we use also the 28D lens, as well as scleroindentation and an eyelid speculum to separate the eyelids. And then on this other part, I'm showing when I'm using the Volkin viewfinder's camera to take an image of the retina. So this baby, we did the first index ROP screening at about 3 weeks of chronological age, because we were using the criteria of having at least 31 weeks of postmenstrual age. And so at 32 weeks of of corrected age, or others say post-menstrual age, that's when we did this first screening. And the baby, by that time, we were using the same birth weight. That's why I didn't put the current weight, since that time I didn't have its recording. But anyway, in this, when after having done the indirect ophthalmoscopy and then documenting with the fundus images, I tried to display the right eye on top as the optic nerve is on the right side. And then the left eye, I put it down with the optic nerve head on the left side. And this shows that the vessels are quite immature. They're not very, big in caliber, and yet also their length doesn't exceed zone 1 of the retina. So we shall be discussing in the future slides what is really what are the zones of ROP and what are the stages of ROP per se. But nevertheless, at this stage, the child did not have ROP. The child just had immature retinal vessels and supposed to be reviewed after 2 weeks. Zone 1 vessels could be also reviewed as early as 1 week, but we didn't want to do frequent screening, so we just put at 2 weeks, and the baby was still admitted. Nevertheless, when we came back after 2 weeks, I wanted to come at 2 weeks, sorry, but the baby had been discharged, and the parents weren't yet accepting the screening that early. And I had to hunt them down via outpatient department and even calling them. And since I'm a friend of the dad, I had to convince the dad that, hey, it's now overdue, the first screening, because the screening was at 3 weeks, and I had to do it when the baby was 5 weeks. But now I saw the father again when the baby was 7 weeks. So it was 2 weeks late from the 2 weeks that was recommended. And but anyway, there we then saw in the right eye, stage 2 ROP, but I called it stage 2 to 3 because this ridge is starting to become raised. And then these vessels are somewhat tortuous, but not very, and then some are engorged, and so that you could call preplus disease. And then in the left eye, we saw stage 3 ROP, which is a neovascularization of the ridge. But this neovascularization is quite hard to appreciate on the fundus camera alone, but on the indirect it was much more clear. But you can see a ridge and then fenestration of vessels which are penetrating that ridge in the left eye. And we see some sausage vessels or something that like a conglomeration of the vessels that then are not kind of releasing any hemorrhages yet, but they form this kind of swelling where the stage is on the temporal side of the retina. So we could call this side, there's the nasal side of the retina. That's why it's very close to the disc, actually almost just 3 disc diameters from the optic disc. And then also on the temporal side. So I regarded it as stage 3 ROP as going with the worst staging, because some other zones had some pockets of stage 2, but we usually use the worst stage for staging. And I recommended the baby to receive treatment within 3 days from this diagnosis, because we wouldn't risk these vessels disrupting and then leading to retinal hemorrhages, which would then lead to vitreous hemorrhages and complex the treatment of the ROP. In any case, when we treated the baby, within those 3 days, we then reviewed after 4 weeks, after the the intravitreal bevacizumab or Avastin injection in both eyes, which was done under a septic technique. The ROP had resolved or regressed significantly in both eyes. You can see the right eye, the vessels are quite okay, and the optic nerve, just that in the temporal side, it shows that the vessels are still growing. They don't finish the whole periphery of the retina. So they stop in about zone 2 to 3. When you come to the left eye, which is the one that had stage 3 ROP, you don't see any sign of stage 3 ROP, but this is at 4 weeks. Someone might ask, how did it all vanish that quickly? Anyway, that's the advantage of early treatment of ROP. But also, I then have documented different grades of stage 3s. Maybe I would have called this a stage between 2 to 3 ROP, because it really regressed very fast. And some stage 3s don't heal that very fast. But anyway, in the side, this I call PAR, or we call it in ROP like peripheral vascular retina. We're seeing the vascularized retina is stopping somewhere, but it's not a stage of ROP per se, but the vessels are stopping somewhere like in zone maybe 2 and 2 to 3. And so that's the PAR, or we call peripheral avascular retina. So we have to follow up this baby in a time frame of between 4 to 6 weeks. So I have to emphasize on the parents to return the baby for regular screening to see that there's no reactivation of ROP and that the peripheral vascular retina has really been vascularized well. So this is the discussion. Retinopathy of prematurity has been well documented for about the past 70 years. But the documentation has been increasing more gradually along the years and decades, as we have also got better means of documenting the fundus images and the treatment modes that have evolved. Anyway, but what is it? It's the abnormal growth of the retinal vessels in the preterm babies. So ROP doesn't affect term babies, meaning those born at 9 months are already born when the retina is fully well developed and the vessels are well developed. So it affects the vessels that are immature. The prevalence of ROP differs in different countries. And in the whole world, it's from as low as 9% to about 70% in different countries. In Uganda, the study we did in 2022 and then published last year, that was at Mulago and Kawempe, it showed a prevalence of combined facilities being about 6%, but in Mulago Women Hospital alone, it was about 18%, and that was very significant. The estimated number of preterms that are getting ROP worldwide in 2010 was estimated to be about 184,000 preterm babies. But those who become blind due to it annually, it's about 50,000 cases of blindness due to ROP. That's very significant. And it's like a third, roughly, or maybe you could say, roughly a third of those who do get ROP might be having a chance of getting blinded due to it if they are not screened in time and treated in time. Africa's prevalence is the one that strikes as highest, and that was in Egypt in one of the facilities. And why do we have to be concerned as Uganda is because we are, I think, number 28 globally in having the highest numbers of preterm births by the studies that were done in 2012 by Blancoe. And that estimates about 14 preterms born per 1,000 births as our preterm birth rate. So with the increasing survival of our preterm babies and all babies in general, we need to fight about how these babies will live. Just like when the story of Stevie Wonder came in, as he's one of those who have been blinded due to ROP, that time there were different things that were happening, and this comes to this topic of the third epidemic of ROP. In around the 1940s, that was the first epidemic of ROP that was documented or described. And for the next 20 years, we were in that epidemic globally. But I cannot mention sub-Saharan Africa part of it because maybe our preterms weren't surviving that much. That was in the colonial age. But globally, I mean the developed world that was struggling with ROP at that time. So for the next 20 years, the babies of about 1 to 2 kilograms birth weight, they were again getting blind due to what was described as retrorental fibroplasia, as scarring behind the lens. And this was linked to unrestricted, unmonitored oxygen supplementation. And then they started to restrict the oxygen therapy gradually. Then suddenly there was a drop of the number of the ROP cases. So in the 1970s, they saw some drop, and also in the 1980s. But as the 1980s were ending, we see something, again, a second wave of ROP comes on, then they named it a second epidemic of ROP. In this epidemic, the babies were extremely premature, and they had very small birth weights, which were less than 1,000 grams, meaning now these were surviving more. Meaning before, these weren't surviving that much. So that's why the ones between 1 to 2 are the ones surviving kilograms. So those now less than 1 kilogram were the ones getting ROP. They are getting the oxygen and everything. Now the third epidemic, which we are now facing in our setting in Uganda and other countries related to our settings, which is not depicted in this graph, unfortunately, but it's in the low middle income countries, just from around 1990s onwards till now. There is a mixture, a blend of the first and the second epidemics of ROP, high rates of severe ROP in both mature and immature preterms, meaning late and early preterms. And the reason is because firstly, we're not screening enough, and we don't have screening protocols or guidelines, neither do we have the babies treated. Because anyway, since the screening is not adequate, definitely treatment is not adequate, and then we shall have blindness registered. What are the risk factors of ROP that have been well documented? The major ones are the very low birth weight, as I've described and narrated in the epidemic slide. And the lower the gestation age also, that means the younger the preterm will be, the higher the incidence of ROP. The high oxygen concentration as well is one of the risk factors of ROP. And this has been well documented across these previous decades, especially the non-blended oxygen, the oxygen that is just as free flow as we describe it in our setting. That is really one of the major risk factors. The baby we had managed, we recognized that the baby had neonatal sepsis, and so was being managed for that. And the low gestation age has also been documented as 29 weeks of gestation age. That was quite low. And the blood transfusion, intraventricular hemorrhage was also recorded in this very baby, which was, I think, grade 2. And respiratory distress, which was really managed, as Dr. Anita has narrated, about using also the CPAP, even from birth. really, the baby had many of these risk factors. And putting this into play, we must recognize also something about the role of some protective factors in ROP. I'm trying to blend the case as well as other reality discussions on ROP in general. So there is a protective factor seen in exclusive breast milk being given to the babies. I know, yes, this baby was on exclusive breast milk, but even if the baby got stage 3, I would hypothesize and say this stage 3 wasn't as severe as some other stage 3s I'll show you. But I'm not saying that I'm putting the breast milk as the main only protective factor in this baby, but definitely it has been documented that breast milk does have long-chain polyunsaturated fatty acids that counteract the oxygen-free radicals, hence preventing the baby from getting worse stages of ROP. But stage 3 is really a bad stage in our setting in Uganda, because the last stage we can manage in our setting, actually in East Africa. So it's the worst case scenario, but there are different appearances of stage 3 is my point in this. Anyway, oxygen and ROP, there is really a happy marriage in this. Why? In our study we did in 2022, which was the first study of ROP in Uganda, but also in view with other studies that were done earlier, it's shown that the longer the duration on oxygen therapy, the higher the risk of having ROP. Just look at Mulago Specialized Women Neonatal Hospital versus Kawempe. The duration of oxygen was about a median of 7 days. 7 days. The babies were on at least 7 days on oxygen in those in Mulago, and that's why their prevalence was higher, about 18% in Mulago. While Kawempe, it's about 3 days on oxygen therapy. But the most important thing was supposed to be monitored was the SpO2s, but unfortunately our study couldn't monitor that and get the average or the median. Nevertheless, if you see oxygen therapy, again, the babies in Mulago Women Hospital, 98% of them were on oxygen therapy, versus in Kawempe, which were about 70% on oxygen therapy. Another thing I would want to note on this is the babies in Mulago Women Hospital, they are on oxygen that's not blended. Some people say non-blended or unblended. So it's not blended oxygen. So even in Kawempe, it's not blended oxygen, but in Mulago, the babies are getting oxygen directly from the wall unit, and each baby has a quite adequate supply of oxygen, I could say, in quotes, or too much. But in Kawempe, they improvise using the Y connector, which I'm actually zooming into this. And then it improvises to kind of supply oxygen on a range of about even 6 babies or 6 to 10 by splitting the oxygen from the main supply. So the babies will get less oxygen in form of saturation, but then the babies in Mulago will have much more oxygen. I think that has to also be studied in a different way as a specific item for in-depth study, because some of them may suggest that, okay, there might be a lower survival because the babies won't get enough of their saturation that they need, versus them getting ROP, they'll have less ROP. Anyway, I'll not expand on that much, but our baby in Mulago was on the oxygen that was directly supplied from the wall unit. This is something I saw in India that is being improvised in some rural Indian settings that do not have blenders, and it's something we can embrace as Uganda, which is like an oxygen hood, which somewhat blends oxygen within the atmospheric air that is near the baby's head. That is quite something good. There's some other study in in Egypt, which was showing that the different ROP cases being recorded in the different stages versus the oxygen therapy that was administered. And it's shown that stage 3 ROP, you see, was more prevalent or more common in those who had oxygen therapy administered, and all other stages of ROP, definitely. But when oxygen therapy is given, there are more chances of having ROP. So it remains an important risk factor in retinopathy of prematurity. Normal retinal vascularization versus the ROP pathogenesis. I want to zoom in this first. So the retina, when the baby is born at 37 weeks or 38 or 40 weeks, the retina has finished its vascularization process. When a baby is born before term, like at 32, the retinal vessels haven't yet completed. Maybe they might have completed the growth of the vessels in the nasoretina. But if they're born at 29, for example, our baby was born at 29 gestation weeks, that's why in the round nasoretina, we would see the stage 3 near that side, because the baby was born when the vascularization hadn't yet completed. And so, but we discharged from ROP screening at 40 weeks or 41 weeks because of this hypothesis that by 40 weeks of gestation age or post-menstrual age, or what you call corrected age, then the retinal vascularization is expected to have completed in the whole of the retina, both the temporal and the nasoretina. So let's try to digest this. I'll try to make it very simple. In utero, in the womb, there's a perfect environment for the development of the retinal vessels in the baby. And due to the insulin growth factor 1, which is provided by the placenta and the amniotic fluid around the baby, that maintains that equilibrium. But if the baby is born prematurely, the insulin growth factor 1 drops. And so after birth, the retinal vasculature kind of slows down in its growth rate. Why? Because of the low insulin growth factor 1. But not that alone. Something then happens. Remember, we shall now give oxygen to support the baby's lungs because they are anyway immature and they need some oxygen supplementation. So, but even with addition with the higher ambivalent oxygen plus our supplemental oxygen, there is then a decrease in the vascular endothelial growth factors and then a rise in the reactive oxygen species. This then causes an injury to the newly formed fragile endothelial cells that are around the retinal vessels of these babies. Then this causes capillary disruption, or what is seen as the capillary constriction. And then you'll have some part of the retina being avascular where the vessels haven't reached and another being vascular. Then if oxygen stress continues, which often does, then the reactive oxygen species will increase in their concentration. And then we have a decrease in the erythropoietin, and then this causes an increase and surge in the vascular endothelial growth factor again, which acts at the edges of those abnormally growing capillary vessels at the avascular border. Then there is angiogenesis, or like new vessels being formed, which are fragile. They look like the brush-like vessels of sort, and these can bleed easily, and that leads to the fibrovascular proliferation and the retinopathy of prematurity, different stages that we do know, and eventually might lead to detachment if not worked on early. Steps in the ROP screening, what exactly do? We first sensitize the masses or the mothers who have gathered about what we are going to do. Every day we come, we have to tell them, oh, hey, the mothers whose babies are above, let me say 3 weeks or 4 weeks, when they're born as preterm, please, we need to check their eyes. And this was actually aired on the NBS television on the World Prematurity Day, as showing what we were screening in Kawempe Hospital as facilitated by Mama Tulia organization. Anyway, we gather the mothers and tell them what we're going to do, that we're going to even drop an eye drop into their eyes, which is the dilator, and then we register them and then start attending to them at 30 minutes from the dilatation. That's when the eye drop has started to work to dilate the pupils. And then we use the indirect ophthalmoscope and then use the fundus camera to document the findings of the retina. So what do we see exactly? So there's a wine goblet hypothesis and use that to compare and understand the stages and the zones of ROP. I'll start with the stages first. The stages is what is happening at the retina. For example, this wine glass could be broken, and the slight the crack, the less the stage. The bigger the crack, the worse the stage. So stage 1 is just a demarcation line. Stage 2 is a ridge, which is somewhat raised. Stage 3 is neovascularization of that ridge and extraretinal kind of fibroproliferative tissue growing at that ridge, and that is stage 3. And stage 3 has very many appearances, and I'll be discussing that when I'm going to show you the slides. And why I labeled the other baby's eye as stage 3 and not just as stage 2, and to act timely, to treat timely, to save the baby's vision. Stage 4 has 4A and 4B. 4A is when the macula is still attached, and 4B is when the macula is totally detached. Stage 5 ROP is total retinal detachment, which can never be treated anywhere in the world. What are the zones? The zones are the wear. The wear, when you compare with the wine glass hypothesis, where is it nearer the stalk? If it's nearer the stalk, it's more important because you cannot carry your glass if it's broken at the stalk anyway. But if it's broken at the edges, maybe you could carry and use it at the other side. But then how much that is pertains to the extent of ROP, which we're no longer using that much in this new classification, but it would tell us in that zone, how many clock hours were we using. So anyway, zone 1 is the most important. It's the parliament, or it's the ruling house of the country. And if you attack it as a person or an enemy, you've taken over that country. Why I use this as an analogy is because it's where it's the visual centers. That's where the optic nerve is and the macula. Doesn't mean we should ignore other places of the zones on the retina, not exactly, but that's what is most important on early treatment requiring ROP. Remember, the other person had stage 3 ROP in zone 1. So that's why we had to treat very fast, this very baby we're discussing. Then zone 2 is the circles just surrounding that, and then the crescent that remains to complete that is the zone 3. There are specific dimensions they do measure this for, but I won't confuse you, but this is how it really appears. And now, this is the thing. This is the thing that is very challenging. And I put the baby's photo, the one we are discussing today, in the white frame. You can see this in the middle. Because it's a continuum, and not just, stage 3 cannot be seen the same way in all babies. It's my proposal or my suggestion or my hypothesis. Why? Maybe this is stage 2, but with double ridges, and I cannot regard this as just stage 2 alone. So sometimes we call this as stage 2 to 3, this one that I'm zooming in on the left side. Then when we come here, this is now really a vascularized ridge. Let's agree to that, because there's a redness between the two lines. Now this baby, the redness is somewhat there, but it's like the shadow in between the two ridges. But then there's fenestration of vessels coming to that ridge, and I can't agree to just call it a stage 2. And it's in zone 1. That was scary to me. And then this is one other baby I'd seen during the study in 2022 in Mulago Hospital. And this is a ridge that is entirely vascularized. Where there's a purplish hue is not what I'm focusing on, but just slightly above it is where the vessels are tortuous, as if there is really plus disease at the stage. Yet plus disease is supposed to be seen only near the optic nerve head. And so that is also stage 3. Imagine, then this is also called a stage 3. This is not taken by me. This is taken by the people who have the red cams and also the 3-nephra neo, a very clear image, which shows maybe what I was seeing here. We're using the evolving viewfinder's camera. This has a wider field of view, as you can see it very well. And this is really a vascularized ridge. Now, in our setting, do we need to first wait for this to happen like this to treat? My suggestion is not exactly. Why? Because I've also seen some who come to me very late, and this is how their stage 3 looks. It's like the vascularization has completed its role on the ridge, and now the ridge starts to get a 3-dimensional aspect. It's almost getting a tractional pull on the retina. And this is one of the worst stage 3s I've seen. When you do indent, my indentation is the other small semicircle, which is at the edge of the avascular retina. But then this is really a retina starting to fold up. I would have argued that this might be called a stage 3, which is eminent to end into a stage 4. Now we can't say 3 to 4, but really it's a stage 3 that's really almost progressing to stage 4. And these you can never observe. So these are some of the images we have taken along the time, and some of these are from the study I did. And this is ROP, or used to be called APROP, aggressive posterior ROP, where the vessels are very tortuous. You can't stage it, and they're engorged, and you have to treat within 48 hours. This is zone 2. Stage 2 ROP, sorry, and zone 1. Why zone 1? Very close to the disc. As I told you, the disc and macula are the most important. This is plus disease because the vessels are also tortuous, and this I took in the during my study, the first study of ROP initially. Why is this stage very weird? Please ignore this other white thing. It's an artifact thing. When I shared this with one of my ROP mentors in India, they was very surprised to see a stage 2 ROP near the optic disc. Even the CIBA mentors of ours who come from Stop Infant Blindness in Africa, who come from US, when they saw that, they were like, maybe this is a blend of oxygen-induced retinopathy with the ROP. So we are seeing different things that are not seen elsewhere because we have different challenges in our resource-limited setting, and we still have non-blended oxygen. This is the stage 3 I showed you earlier, and this is the stage 4. The best way to show a stage 4 is the ocular scan or the B scan. It really shows the retina that has detached and the macula still being in situ. This is the stage 5 ROP, which we have seen really very frequently with those babies coming late at 6 months of, let me call that chronological age. Or maybe from birth is the chronological age, 6 months from birth, or 7 months or 10 months from birth. They come when ROP has completed all its natural course of manifestation, and it has come as the worst stage of retinal detachment. Unfortunately, not every leukocoria, not every white eye is an ROP, because we have seen some babies with one eye with retinoblastoma, the cancer of the retina, and another eye having stage 5 ROP. So, but all can look white, and some may think it's a cataract, but the scan can show you with like a chewing gum, a closed funnel retinal detachment. Unfortunately, a camera cannot enter through this, and that's why a scan is needed. So the regression of stage 3 ROP following intravitreal bevacizumab injection in this baby is a very successful thing we have seen, especially in the left eye, which had stage 3 ROP in zone 1 with plus disease. And so we urge you for early treatment for better regression. Because if this baby had waited for an extra month from diagnosis, that's why I emphasized 3 days. Because earlier when I told the father, who is a colleague of mine, so that we screen the next review maybe in 2 weeks, it was made double the time frame I had planned for because of the unwillingness of the parents. But if I'd said the treatment, treat within 3 weeks or treat within 2 weeks, imagine this stage 3 would become one of the other severe stage 3s. And why do I talk about that now? Because the healing will be different. This will heal with a scar. Definitely, I've seen some of these, they heal with a scar at the retina. And this has high chances of reactivation. And these two, these stage 3s, those last 3. These ones do heal quite very well without chances of that much reactivation, without scarring of any kind, just as we have seen in our baby. Anyway, their screening criteria is in India, they screen in less than 34 weeks of gestation age at about 3 weeks or 4 weeks from birth, the chronological age, and they screen all those less than 2 kilograms birth weight. That's what is done in India. And Kenya also has a similar guideline, but they use more of the birth weight than the gestation age because they have a challenge. Like us, some babies, gestation age is not well documented, as the Ballard score is not well recorded in some settings. The control strategies, the prevention is of 3 kinds: primary, secondary, and tertiary. Prevention, if we would prevent preterm birth, maybe we would have done that, but we can't prevent that in all cases. But we need to prevent ROP by improving our quality of care, by restricting oxygen therapy. And this is the targeted SPO tools that we should see after birth. If that graph is hard, or that chart is hard, sorry, the table is hard to maybe memorize, or we just use a range of between 84% or 85% to 95%. This last one that is shown at the 10-minute interval, because anyway, in the NICU, we're going to find the baby after those first 10 minutes from resuscitation from birth. And so that's the range that is safest for them. Never go beyond 95% of oxygen supply to the baby. Then we must really advocate for timely screening and treatment, and struggle and fight that we can have national guidelines of ROP in our country. Currently, we are screening all preterms really less than 2 kilograms of birth weight, like Kenya does, irrespective of their seemingly reported gestation age, especially if we do not have well-documented Ballard score or ultrasound scans that were done in the antenatal period. Because that's what happened in some public settings, that we do not have confirmed gestation ages of some babies. Now, in the screening, there are lots of equipment we can use, and I had improvised one of these tools during my study when I hadn't yet got my Vulcan viewfinder's camera. But this was like a lens and a pipe and the phone on the other side, and it was a do-it-yourself RETCAM. The disadvantage with this, it has a narrow field of view, so you cannot see some parts of the peripheral retina. And so this is the Vulcan viewfinder's camera that was lent to me by one of my lecturers, Dr. Mpaire, during the study. And so it helped me, but it wasn't actually made for ROP. It was made for diabetic retinopathy, but it's what I use now because I tweaked. I borrowed the idea from the do-it-yourself RETCAM to then apply it for this. This was used for only pandas photos and not videography. But then I used the idea of taking a 1-minute video clip that I had harnessed when I was improvising this pipe. And then I applied on this by using the video mode, and then take a 1-minute video clip and then extract the necessary images of the diseased retina and the peripheral retina, as well as on the nasal retina, like I've shown you on the photos, and it works very perfectly well. Then the gold standard is really the indirect ophthalmoscope, but unfortunately it doesn't take an image, so it's just you, the ophthalmologist, who can see, but you cannot explain to the parent. I've seen that the images help very well. The parent, you tell them in Luganda or Lutimberwama, so that means the screen of the eye, something like that is what we use. It means the screen of the eye, the back of the eye. And you tell them this is the scar that is happening on your baby's retina, and they really see it during the images that you've shown them, and they really acknowledge what you're explaining. The RETCAM is this one, this side. It's really a very good device. It's the one that showed the other stage 3 that I was showing. It's a very clear modality. The one that I said is from textbooks and from abroad. We definitely don't have it in our setting, but I think Zambia Hospital has a Phoenix camera, which is close to a RETCAM. It's quite expensive. Then the other that I saw in India that was being improvised in the rural settings was the one made by Forest Health in India, which is the 3-netra Neo. The image looks somewhat as clear also as the RETCAM's image. Yes. Then the other tertiary prevention is kind of we're working on those complications of ROP, like the retinal scars, and then rehabilitating those who are turned blind due to ROP. But even those of stage 4 that has detached, they must be assessed by a pediatric retinal surgeon to see if they can do some vitrectomy and save the vision, even if it's ambulatory vision. In Sweden, they have the SwedROP register, which recommends every NICU must have an ophthalmologist that covers it for the ROP screening, and that is important. And their SwedROP is one of the biggest ROP databases worldwide. This is one of my struggles as I journey into some roads like going to Kiwoko Hospital to screen some babies for ROP on Mondays. Anyway, the timing for ROP treatment and when do we treat? So it's recommended type 1 ROP using the Iddi ROP study. It recommends treatment within 48 to 72 hours. And for which stages? I start with the worst stage and its zone. For any stage 3, in zone 2, you must treat even if it's without plus disease, because stage 3 has a chance of turning into stage 4 anytime, like I've demonstrated there continue. Then any zone 1 disease without plus disease should be, any stage in zone 1 without any plus disease should be really treated early. And so that's why we treated our baby within the 3 days when we had a stage 3 in zone 1. But if you have stage 2 in zone 2, it should be with plus disease for you to treat it quite early, because some stage 2s we have seen them quite responsive on observation. Just on follow-up, if the mother is on exclusive breastfeeding, we do see some regress on observation. Type 2 ROP is the one that is less risky. You could watch closely. You can follow up within a week. The problem with the Ugandan setting, if you do say within 2 weeks, the mother will make it 4 weeks. That's what I've seen. I don't know why, but that's what happens. So really state like 5 days or 1 week. It's hard. If you said 2 or 3 weeks, they come after 2 months, and that's a challenge. The stage might have gone to another and not regressed. So treatment options, laser is the gold standard up to now. Cryotherapy was outdated, but in Uganda, we are mostly doing the anti-VEGF, anti-vascular endothelial growth factor, alone. But in Australia, some of my ROP mentors, like Professor Susan, they do both, the adjuvant, both laser and the anti-VEGF. And we are really, yes, bevacizumab injections, because that's the anti-VEGF. We also have other anti-VEGF components like ranibizumab, but it's more expensive, and also Eylea, which is aflibercept. It's also quite more expensive than the Avastin or bevacizumab, but all options are available. And then the surgery is retained as vitrectomy for the advanced stages of ROP, like stage 4 ROP. And most people in India stop treating at stage 4A ROP because 4B is definitely very close to stage 5 and the visual prognosis is very poor. Highlights from what I've just mentioned is that ROP is a retinal disorder that affects the preterm babies. It's one of the leading causes of childhood blindness worldwide, and Uganda is not exclusive. And this case was describing a 7-week-old preterm neonate who was diagnosed with stage 3 ROP in left eye and stage 2 to 3 ROP in the right eye, but both were in zone 1. Anyway, we then saw regression of ROP, total healing of the ROP after 4 weeks of intravitreal bevacizumab injection in both eyes. The hypothesis I suggest was timely administration of this treatment or intravitreal bevacizumab aids in the earlier ROP regression, especially in our setting, which is challenging in the follow-up. We need to screen timely, treat timely, follow up timely. The key points to note on ROP prevention versus oxygen management in neonatal care, we need to really fight in the battle to have all babies to be on blended oxygen, or at least improvise with the hoods and give oxygen only when it's needed. We have to screen ROP for all preterm babies till we have national guidelines, which we must fight for. The NICUs must have a ROP expert covering them, or people trained in ROP, to cover them timely for timely screening and treatment of ROP. And we need to have multidisciplinary approach for advocacy in terms of having safer neonatal care practices. Neonatologists, ophthalmologists, actually even obstetricians should also be on board. Why? Because they're the ones who give help in the delivery process for these preterm babies. And there's a resuscitation of the other first 10 minutes, meaning even in the first golden hour. So they need to also be on board about the safe oxygen practices. National policies, we need their help to help improve the outcomes of ROP, and more awareness is needed amongst health workers and parents. This is a short poem I composed about ROP, but because of time, I may not narrate it. Thank you very much.
Thank you ever so much, Dr. Anita and Dr. Iddi. I think this is just a really amazing example of the importance of multidisciplinary teams in any form of medical care, but most especially neonatal care. And I think both of you have highlighted it so well, and there's been a number of comments in the chat, but as we see our preterm survival increasing here in Uganda, and a number of district hospitals, regional referral hospitals creating neonatal units, and indeed soon to be NICUs, focusing on preventing ROP is really key. We all need to go away and think about how we can better monitor our oxygen of our preterms, and how we can advocate for blended oxygen. Just as a simplification here, at least in Mbali, we only add oxygen at 5 minutes when the SATs are below 85%. So I think everyone should take a simple learning point, is that 85% Iddi that you mentioned is really key, and that goes to obstetric colleagues as well, and aiming for our 90 to 95 in the neonatal unit. And as we introduce CPAP in our neonatal units across Uganda, introducing CPAP in conjunction with bedside pulse oximetry is really key. I'm not going to take questions now, if that's all right. We have got a little bit short of time. I'm going to come on to the next speaker, and then hopefully we will have a little bit of time at the end for some questions and answers. But it was just a fascinating and eye-opening presentation for all of us here, who are mainly pediatric and neonatal in origin, both doctors and nurses. And I think we rarely have the opportunity to interact with ophthalmologists. So thank you for highlighting those challenges. If people want to show their appreciation, I would love to see some flowers and clapping and words of appreciation in the chat. In the interest of time, we're going to move to Dr. Yousef Gargani. He is a consultant neonatologist at Bradford Teaching Hospital in the UK. Dr. Yousef, please go ahead. Share with us your experience of retinopathy from the UK side. Thank you very much.
Thank you so much for having me. Good afternoon, everyone. It's lovely to see so many people virtually. And as I said, thank you for having me. And thank you very much to Dr. Anita and Dr. Iddi for sharing your experiences. It's really eye-opening and inspirational, all the hard work you're doing. So thank you. So hopefully technology is working and you can see my slides. The first most important thing to remember is I'm not an ophthalmologist. Unlike Dr. Iddi, I'm a neonatologist. So this is from a neonatologist perspective. We did try and get our local paediatric ophthalmologist, but unfortunately she had a clash in her diary today, so couldn't make it. So I will just tell you about retinopathy prematurity from our neonatal perspective in the UK and how we approach it and manage it. So a really quick recap of some of the stuff we've already talked about, but Stevie Wonder was a 34-week gestation baby who was born in the 1950s, and at a time when everyone thought oxygen was fantastic. Oxygen's great, let's give loads of oxygen to our preterm babies. But unfortunately, 8 years earlier, T.L. Terry, an ophthalmologist, had diagnosed or found a condition called retrolental fibroplasia, which he had already associated with preterm babies and hyperoxia. So despite this being published 8 years earlier, Stevie Wonder became blind, and it is almost completely preventable. We would never see a 34-weeker nowadays in this country and America being blind from retinopathy prematurity. And it took another 4 years after that for the American Academy of Ophthalmology and Otolaryngology to recommend minimizing oxygen use in preterm babies. So why did it take 12 years? So I think the only reason I have this slide is to remind us all that we have a duty to our babies and our patients to constantly be appraising research that's coming out and seeing if we can improve the care we deliver. We can't simply just sit back and do what we've always done. I couldn't find anything important that happened in 1954 apart from the fact that the Lord of the Flies book was published, so that's why that's there. So what is ROP? We've already heard a fantastic presentation from Dr. Iddi. I'm not going to go over what he's already said. He's already showed you this slide, but it's a really important interaction between initial hyperoxia, changes to endothelial cells, changes to the normal blood supply to the back of the brain, and then increase in VEGF and a secondary high.
Yousef, sorry to interrupt you. You've just suddenly gone quite quiet. Gina and I can't hear you very clearly. You started off very loud.
Can you hear me now?
It's just muffled a little bit. I don't know if you put something on top of the speaker or...
No.
All right. We can hear you. It's just you've gone quieter than you did at the start.
I do apologise.
That's better.
There we are. That's it. That's it.
Is that better?
Yes,
Amazing,
perfect.
thanks.
Excellent. Apologies for that.
Great.
So it's a complex interaction between prematurity, insulin growth factor 1 going down, oxygen free radicals going up, and then VEGF in the secondary phase and hypoxia, resulting in these abnormal blood vessels. So we've already talked about the risk factors. So perinatal infection. In our setup, the high risk groups are sort of less than 31 to 32 weeks. There's a bit of a debate about that. Very low birth weight babies, and something that's becoming more and more appreciated is this poor weight gain in the first 6 weeks of life. So if you fail to gain 50% of your birth weight within 6 weeks, that's quite a sensitive marker for a risk of retinopathy prematurity. So it's not just oxygen. I'm really keen to focus on early postnatal weight gain for these babies that are at risk. As we've said, initial high oxygen requirement and sepsis, especially fungal sepsis. So a really brief thought about preterm oxygen saturation targets. We've already talked about what we target in the UK. So in the high risk babies and preterm babies, our nice guidance, our national guidance would be to aim for 91 to 95%. And the question is why? And that comes from quite old studies now, but we had the Boost 2, the COT and the support trials, which were international trials, which were meta-analysed by the NEOPROM group. And they found that saturating 85 to 90 had less ROP, but had more NEC and more death. And so people felt we can treat ROP, let's focus on avoiding death and NEC. So we ended up with 91 to 95 as our saturation targets. Now, there's 2 prerequisites to that. 1, blended oxygen, and 2, saturation monitoring. Now, we're very blessed in our setup to have that. And I think as neonatologists and neonatal units, fighting for those things for your babies will be really beneficial for lots of reasons, but ROP is probably the number one to try and help them going forward. So we talked about that. So we have a national guidance that was submitted a couple of years ago now from the Royal College of Paediatrics, the Royal College of Ophthalmologists, and the British Association of Perinatal Medicine, BAPM. And this is about who should be screened and when. So in our setup, the highest risk groups are 31 weeks up below or less than 1.5 kilos. Now, we've recently had a baby that was over 31 weeks who ended up having ROP that needed laser. So we've gone back to the old guideline transiently as there is a discrepancy. So we're back to 32 weeks and less than 1.5 kilos. So when should they be screened? So it depends on when they're born, but essentially around, if they're born less than 31 weeks, around 32 weeks or 4 weeks, whichever is later. And if they're born after 31 weeks, it's around 36 weeks or 4 weeks, whichever is sooner. And we audit these to make sure that we're achieving these. And actually, we're very, very lucky. We have a really robust governance system around this. So we thankfully don't miss many ROPs. So we've already talked about the different zones, and we've talked about the different stages. So stage 1 being a thin line, stage 2 being a ridge. You then get this abnormal proliferation of blood vessels towards that ridge, that abnormal, as I said, vascularity around that ridge. You then have the partial retinal detachment, and then the stage 5 is complete retinal detachment. We very rarely see this in our setup, thankfully. I've seen one 22-weeker who had stage 5 and went down to Great Ormond Street in London and had a vitrectomy, which had a good effect. He had some vision in that eye. So there is some treatments for these really severe ones. But as Dr. Iddi rightly said, prevention is the key, and spotting it when it's early and getting in there early. And we talked about plus disease, which is about this arterial tortuosity and these venular dilatation. So when should you treat it? So our national guidance says that if you're in zone 1, in that important zone, as Dr. Iddi said, if you have any ROP with plus disease, you need to intervene. If you're in zone 1 and you've got stage 3 without plus disease, you need to intervene. Or if you're in stage 2, zone 2 with stage 2 or 3 with plus disease, you need to get involved, and you need to treat within 72 hours. So a little bit about what our first line treatment is in our setup. So ROP laser is something that we do relatively frequently. In our hospital, we do it under general anaesthetic. So we will intubate and ventilate the baby, muscle relax, give them some opiates for sedation and pain relief. And then our expert ophthalmologist will use a diode laser to burn many hundreds, even thousands of burns on the back of the eye, and we'll show a picture of that. Now, because it's a surgical procedure and it's very high risk, we have lots of governance around that. So we have a checklist to make sure that we do it safely. And this is just a part of a 4-page document about how we do that safely. So that's something else that I think we've evolved over the last sort of 10 or 15 years, in that we don't take these things lightly. We treat them really seriously, and we use a really robust sort of checklist and governance processes, auditing, to make sure that we get the best outcomes for our babies. So what does it look like on the back of the eye? So we've talked about the diode laser. So here we have a baby who has established ROP, and this is what the laser looks like afterwards. So many hundreds or even thousands of burns, stopping these abnormal blood vessels from carrying on and proliferating and pulling the retina from the back of the eye and causing that retinal detachment. Now, what are the pros? So the good things about laser surgery is it can be done in the nursery. They don't have to go to a different hospital or theatre or anything like that. And it's very effective at preventing progression and retinal detachment. The cons in our setup is intubation. So these babies may have chronic lung disease, and therefore going back on the ventilator might not be good for them. They may go back a step in terms of their respiratory support. Unsurprisingly, burning the periphery of the eye affects the visual fields, and that's something that the families need to be aware of. Their child will have reduced visual fields and reduced vision, but at least they'll have some vision. There's a high rate of refractive errors, so a lot of these children end up needing glasses, and there's some suspicion, some concern that it may increase risk of cataracts, but the jury is still out. So as we said earlier on, VEGF is a really important growth factor when it comes to the proliferative vasoproliferation phase. And if we can target that, maybe we can reduce ROP. And that's where the monoclonal antibodies, the Lucentis and the Avastin, come in. In our practice, we tend to use Lucentis, but Avastin has been around for longer. And what are the pros and cons for anti-VEGF? It's really quick. As I say, I don't do it, but I hear it's quite quick. It's much cheaper than laser. You don't have to intubate. You can do it under local and have a really strong nurse holding the child. It works immediately, and it has really, really good regression rate, and it may have better rates of myopia and refractive errors. So that's really good, eh? That's good news. The cons, obviously, there's a risk of infection and even loss of the eye if the eye gets infected. Recurrence is a much bigger issue compared to laser. Therefore, you have to monitor them more closely and for a longer time. And we're not sure which drug is the best drug, which anti-VEGF is the best one. And theoretically, there is a risk of systemic action on the brain, lungs, etc. And in our setup, most places use the injection as an adjuvant therapy to the laser, either as a rescue therapy, or if the ROP is very close to where the fovea is, the laser would interact with that. Therefore, they'll go for anti-VEGF instead. What about the future? So there was a study quite a few years ago now looking at prophylactic propranolol to reduce angiogenesis. We use it obviously in hemangiomas, and it apparently was very effective in reducing severe ROP with a number needed to treat of 3 to 7. However, there's quite a high side effect profile in terms of hypoglycemia, low blood pressure, etc., bradycardias. And perhaps the future is gene therapy. So hopefully I've ticked off some of the objectives on this list of things we're going to talk about today. And I'm sorry I've whizzed through it, but time was short, and I think it's important to answer some questions. So hopefully that answers some of your questions about how we manage ROP in the UK and in Bradford. And I'll happily answer questions if I can.
Yousef, thank you ever so much, and thank you for getting us back on time. That's always helpful as well. We've tried our best to answer some of the questions in the chat. I saw that Dr. Sarah was trying to highlight for us very kindly the use of antenatal corticosteroids. It's something we're not great at here in Uganda, and I think it's a good opportunity to just highlight that often there's this idea that it's just there to prevent RDS, but actually we know with the antenatal corticosteroids, it prevents NEC, it helps with the PDA, it helps with prevent IVH, and now it's going to help us prevent with the ROP. So all I can do is encourage us to work closely with our obstetric colleagues, making sure that we're finding our mothers in preterm labor, giving them antenatal corticosteroids, and if they've got premature rupture of membranes, or indeed if they've got signs of infection, making sure those mothers get antibiotics. The benefits on so many different levels. So I don't know if anybody else wants to raise their hand, ask a question, and also show appreciation to Dr. Yousef in the chat. And I believe we've got Anita and Iddi and Yousef, they're all still online. So if we've got questions for them, please go ahead. There's one I can see now. The question is here, well done and thanks, but in Ugandan setting, our general hospitals, how can one be helped with this retinopathy screening? And it's a fantastic question. It's something that Dr. Iddi and I are trying to address here in Mbali at the moment. And I think, at least for me, the key is prevention. But Iddi, maybe that's a good question for you. How do you see us trying to scale up ROP screening and treatment in a setting like ours? And maybe I just want to add there, Iddi and I recently had a case of a 26-weeker from Mbali who, here we have 24/7 pulse oximetry in our HTU, and we have access to air and oxygen. So a 26-weeker who was managed carefully with oxygen administration, and still by the time we managed to get them to Dr. Iddi had got stage 5 ROP with bilateral retinal detachment. So even if we try our level best to prevent, we also use breast milk because we have a breast milk bank, we didn't prevent the ROP. So we still can't get away from the fact that we need ROP screening and ROP treatment, even if we do our very best here in Uganda to prevent it. So Iddi, maybe you'd like to speak a little bit to that, how you see the possibility of us scaling up in other hospitals in Uganda.
Thank you very much, Dr. Kathy, and thank you, Dr. Yousef, and for the presenting. And the question is a very intriguing question, because we need to know first the levels of care for neonatal babies and all places that ever handle preterms. That has to be well documented. I'm not a pediatrician, but the neonatologist really will help with that. And then knowing which babies whose gestation ages are never known rightly, how we shall track them down. And thirdly, we need really big ROP projects in the country, whereby in India, I saw my Europe mentor, Dr. Parag Kesha. He was covering more than 50 NICUs. And the other bigger ROP project is the Kid ROP, which is in Karnataka. I think they cover more than 200 NICUs. It doesn't mean the ROP expert has to move in all those NICUs, but there is also teleophthalmology. So we need to get the fundus cameras and then train ROP screeners, and really they are certified as well. And then the cameras are well maintained. And the best, of course, we can start with the 3-Netra Neo, keep them for the different regions, and then some other neighboring hospitals can refer their babies for screening at that ROP regional center. That's what I could maybe suggest. It's only those, and then these have to be reviewed within the same hour of taking the image by the ROP expert in the center, in the specific, can I say specific ROP review center for that program. And then those who need treatment have to, or those with any perplexing findings, maybe like retinoblastoma, we have also seen some during ROP screening. Those have to be seen by the ROP experts and the pediatric retinal people and pediatric ophthalmologists, and those who are engaged in ROP treatment, like vitreoretinal surgeons. They have to be seen within 1 week, like when you're planning to treat. And then you have specific treatment centers as well to prevent endophthalmitis. And these have to be certified, and really, it's really building up a ROP working group and mega ROP projects in courts. It can be done by one person, and we need help, really. But yeah, we can start with what we can and help those we can, definitely.
Thanks, Iddi. And I think partly what this grand round is a call to all of those who are interested here in Uganda, try and get together a working group. so that we can try and scale up what Dr. Iddi has achieved in Mulago and Kampala Hospital, Kawempe and Kiwoko. So anybody who's interested, please reach out. Iddi, your email may be slightly busier than normal, but I think this is really the start of something that we very much need here. Yousef, there's a question for you about the propranolol. I suppose, firstly, do you think it should be used as routine? And if so, what dose should people be considering? I would say personally here, we don't have good monitoring of heart rate or blood pressure. So I would be reluctant, at least in our unit, to use it, but I don't know what your experience is.
I was just highlighting areas of future research. So I've not seen it used. I've just put the link to the journal article in the chat. This is quite a relatively small study, but it is in a sort of a setting where I think screening is difficult and laser, for example, is more challenging. And as we've said, prevention is better than cure. So this was, as I say, future research is needed clearly, but it's maybe one avenue in 10, 15 years we may look at and think that's routine care if it's proved safe, but it needs a bit more research, I'm afraid. We don't use it, as I say, or I'm not aware anyone uses it in our setting, but it was just something that I thought was really interesting, that it could be used in areas where screening and interventions are challenging.
Yeah, thanks for that inspiration. And there must be somebody on call who wants to take on a PhD or randomized control trial here in Uganda. And I think the key as well I think the majority of the people on the call today are from the Ugandan side, not all, but many of them. And I think we always need research that's specific to our setting, because even if Yousef did an amazing RCT next year and found the propranolol was effective in his population, it doesn't necessarily then translate to our population here. So perhaps something for the future, and it might be helpful. There's a few more messages coming in. Lots of appreciation. I hope you guys have all looked in there and seen how much everyone has enjoyed your presentations this afternoon. Another question, apart from ROP, would like to know, these days children have allergies with their eyes. Can we relate it to oxygen use at birth or a complication? Maybe Iddi, you could take that one. I think what it's saying is neonates or preterms who have been given oxygen at birth seem to then have a higher incidence of allergy. Do you see that?
I have no answer to that. It has to be backed by research.
Fine, so another PhD someone else could take on. And then Dr. Matthew says, even in the UK, there's a shortage of paediatric ophthalmologists for screening. So they have neonatal nurses who use a retinal camera and send the images to Bradford Specialist. Matthew, I think that's a great idea. It's something Iddi and I at least have spoken about here in Mbali. We're so far from Kampala, as I believe many of the people on the call are. The challenge we have is that the fundus camera is about $50,000 US. And so the indirect ophthalmoscope is much more affordable, but obviously you need somebody trained to use it. I don't know if either Yousef or Iddi want to comment on that. Well, maybe even Matthew, I don't know if you know the cost of your retinal camera that you've got in Bradford, and whether it'd be something we could consider at centres in Uganda.
Yeah, it's not cheap. I think ours was over that, and even here it raised eyebrows when we asked about it. I mean, the issue here was Bradford had two ophthalmologists, so one of them would come and do our screening when he was here for a clinic. We don't have our own ophthalmology team, so when he retired and there was no replacement, it was obviously, in terms of the finances, they're not paying for a consultant, but it's still very expensive. Yeah, I think it was at least £50,000. And then you've got the training. So the nurses had to go over to Bradford to see the volume of cases to get some experience and be able to get adequate images. I know there are potentially cheaper technical options that I'm guessing aren't maybe not as good picture quality, but the high quality ones are very expensive. And when you look at it, I mean, it does seem very expensive for what it is. It is essentially a fancy digital camera that plugs into a laptop. So hopefully it's one of those things that will come down in price, because it is a camera and a laptop at the end of the day. So 50,000 plus still seems very expensive.
Yeah. Iddi, any thoughts on that?
Yes, thank you very much. When I saw in India, they have a blended practice, and there are some NICUs which are surrounding the ROP center. In those NICUs, they don't do teleophthalmology. They do the real physical screening. And I saw that there's a challenge between private versus public facilities. Most of the telescreening is done in the public hospital. I'm just trying to shed a light. And that's where the telescreeners go, or the ROP screeners that have been trained. The challenge is that in Africa, everything is imported. And in India, at least, they make their 3 Neo fundus cameras. Now, it's a challenge that we have to embrace by accepting that we need people who have to be dedicated to ROP. We might not get the gadgets timely, but at least we need people who are passionate about ROP to save these babies' sight now, till we shall sort ourselves in getting the expensive cameras by bigger projects. When will these projects arrive? I have no answer, but the SIBA, or Stopping Fine Blindness in Africa, would like to start something of that kind, maybe into this coming year, but we don't know the scale in which it will be. So some places will definitely not be reached, because even India, they have only 200 ROP experts, and they don't cover all places, even with their ROP screeners that they have trained. They don't. So some NICUs are not covered, but they try what they can. And so we should start with what we can, that some NICUs will be covered by physical ROP screeners, some will be covered by ROP screeners who will be using teleophthalmology. Then some will have to refer their babies to the places that have screening services. And even like in our setting, in the Ugandan setting, even if you've studied ROP as a field, even after ophthalmology, it's not even part of the government or the public service remuneration or remuneration. So it becomes quite hard for you to blend into the public sphere. So you really need, again, a project to just maintain that service. That's something from my side. But the more expensive the camera is, the better it is, because the more expensive cameras are contact fundus cameras. Contact meaning the lens of the camera is going to touch the cornea, and so it can be trained on with a nurse can learn it, any ROP screen or technician can learn it. The non-contact fundus cameras are cheaper, like my Vulcan View fundus camera, but the technique you need is the one for the indirect ophthalmoscopy. And so you must do it yourself or someone you've taught indirect ophthalmoscopy, and the only people taught indirect ophthalmoscopy, again, ophthalmologists. We do have clinical officers in our setting in Uganda, but they're not trained how to do indirect ophthalmoscopy. So you'll need to train them like the technicians, using the more expensive cameras like 3D Netra Neo, or 3 Netra Neo, sorry, or the Redcams. And those are the only two I do know that are quite very perfect imaging, but expensive. Then the non-contact fundus cameras, you just have to tweak them with the video formality, the one I was explaining and I'm using, and then you take a photo of the still fundus where the pathology is. That takes time to also train. I've been training some in Mbale, some clinical officers, but during that short-term project, but it hasn't worked out actually. Because the indirect ophthalmoscopy, the image is inverted, and you're telling them to really focus on the retina, and some of them are somewhat aged people and they shake. I'm not actually talking in a bad sense, but definitely that's the experience I've faced, and I had to really document the challenges faced in the teaching of that tool, the Vulcan View fundus camera. It's not the standard one, because you don't see until you indent well. So those who indent well are those who know how to do the indirect ophthalmoscopy most best. Hope my thoughts could be gathered up to pick some.
That's great, Iddi. And I think the other challenges, even if we do distance diagnosis, if we're still at the stage where we need to give our anti-VEGF in injections, we still need an expert to be able to do that, even if we've trained our neonatal nurse to take the picture and share it, halfway across Uganda. We still need to improve on the training we're not going to get laser like Yousef does, but we've got 2 stops, especially if it needs to be within 3 days. And again, even if we have a ophthalmologist visiting a regional hospital once a week, actually it could be another week before they get the injection. And one thing we haven't even touched on today is the cost of those injections. Iddi, just tell us how much one vial costs of the bevacizumab. I've forgotten how you say it.
Yes, Dr. Kathy, the cost is about 2 million Uganda shillings. Let me just compute that into dollars. Maybe that's about $526 roughly on average. But the good thing, it does treat many babies, not just one baby. And that's why I talked of the centralized ROP treatment programs. So you have many babies to treat, and then the money really comes back and can buy the vial and treat other babies. So that's what I've been doing, and it's really practical. Yeah.
Great. Thank you for that pragmatic approach. Agnes asked in the chat, we're still using oxygen connectors and measuring oxygen as a problem. Agnes, I think it's not just you. I think it's almost all of us in Uganda. Even in Mbali, we've got 10 monitored beds that have got a blended oxygen for their CPAPs. And once you're out of there, you're on 100% oxygen again. What is available in Uganda from NMS and does come in donations from time to time from UNICEF and USAID are the flow splitters. So at least you can minimize the flow of oxygen, which is not perfect, but at least instead of rushing in, 2 to 5 liters of 100% oxygen, you can get it down to 0.1 liters of 100%. So you're not giving so much. But I think the key really for us, even if we can't do 24/7 monitoring, is make sure at least once a day you're going and checking those preterms. Don't just do your observations on admission, and make sure that you stop oxygen as soon as they're able to saturate above 90% by themselves. I think Anita, you're still on. That's obviously experience from a Mbali side. Anita, are you still there? Trying to find you. Is Anita still with us? No, Dr. Jolly. So maybe Dr. Jolly, do you want to talk a little bit perhaps about what happens in Mulago with the monitoring of oxygen? Is it 24/7 or is it once a day? What are we able to achieve at the National Referral Hospital? Okay, maybe we don't have Dr. Jolly with us at the moment. That's okay. And then Mary Goretti says, I want to know if a midwife has a role to prevent this. Dr. Sarah, do you want to talk a little bit? I know you've been mentioning to me that you've got very clear guidelines in the UK about the perinatal management of mothers in preterm labor. Are you able to just give us a brief summary about what our obstetric and midwifery colleagues can do around the time of labor to try and help us prevent ROP?
So I didn't quite get everything you said.
Sorry, someone's asking what's the role of a midwife? What can our midwives? Most of our neonatal units here, as I suppose perhaps in the UK, that we've mainly run by midwives. What is the role of the midwife apart from we've mentioned the giving of antenatal corticosteroids? Is there anything else you could add from your experience of what our midwives could be considering here in Uganda?
Well, it's going to be the midwives and the obstetricians. So our sort of organization that looks into all things neonatal, which is the BAPM group, they produced an excellent document, maybe about 2 years ago now, which kind of helps consolidate, probably is the right word, all of the risk factors that can contribute to that if acted on can help produce the best perinatal I can't get the words out, the best perinatal conditions for optimal delivery. So for in our setting, because of course we have a difference between what we call level 2 and level 3 care, or tertiary hospital and district general hospital, the very smallest babies, the outcomes show that they don't survive and they have far more complications if they are delivered in our center versus a tertiary center. So we have a big push to get those babies in the right place delivered. But something in your setting, because I don't believe that antenatal steroids nowadays are terribly expensive. I think they're relatively a low cost intervention, giving mums who present with suspected preterm labor, if they can have a dose of antenatal steroids 24 hours apart, and at least 48 hours before the baby is born, that makes a significant difference to their outcomes in terms of their risk of developing respiratory distress syndrome, which will prevent the need of high oxygen levels and surfactant, which is quite expensive. As you mentioned already, it's linked to IVHs and duct. Also, you mentioned, I think, in this story that this mum had premature preterm rupture of membranes, which we know is again associated with development of chorioamnionitis and infection in babies. So giving those mums early antenatal antibiotics were indicated to protect against chorioamnionitis is another thing, again, that is an intervention that the obstetricians and the midwives working together can do really well. Certainly in your setting, because I think I listened to a session already on maternal breast milk. I think your rates of mums giving their babies their own milk are fantastic, and that's something that we probably struggle with on this end. But that's another intervention that is there, and getting those mums to express antenatally, especially when preterm delivery is imminent, is really good, so that babies can have their milk very early on. And then there's a lot of work done around optimal management of the cord, and I think again, if an intervention like delayed cord clamping were to happen routinely and regularly, that again helps reduce the risk of IVH and need for early transfusions for these babies, which again I expect might be a difficult thing in resource poor settings. So it was just these are all evidence-based interventions that help in reducing the complications associated with preterm delivery. And I just thought maybe it might be a useful thing to share with your obstetricians and midwives if they weren't already aware of it, to see how
that would be
it could
really great.
match with your setting, and obviously do the things that you could then do well.
That's really helpful, Sarah. Yousef shared it. I've put it up for people to look at as you've been talking. So thank you for summarizing that. I mean, I think one of the key things for us here in Uganda is a place of birth. And most of us will acknowledge that the preterm babies who are born at home or at a lower facility and then referred into the national regional referral hospitals don't do so well. So if you're the midwife and you think you've got a mother who's in preterm labor, trying to get her to a center where they have a neonatal unit or a neonatal intensive care unit so that they get the best possible level of care. And then I think another key factor down here is maintaining a normal temperature. And I think we had a presentation not so long ago about immediate kangaroo mother care, which is something that we're all trying to push. So as soon as these babies are born, getting them on skin to skin. Just the most fascinating presentation and a really stimulating discussion. And I want to appreciate everybody for joining the Scale Neonatology Grand Round. For those of you who joined a little bit late, this is a partnership between NHS England and Uganda Ministry of Health, supported by UK-Uganda Health Alliance. And we've been really privileged today to be joined by Dr. Anita, consultant paediatrician from Mulago Women's, and by Dr. Iddi, one of our only ROP specialists in Uganda, and then Dr. Yousef, consultant neonatologist from Bradford. So a huge appreciation to all of you for taking the time to prepare such wonderful presentations and delivering them so eloquently, and for everybody who has joined us today and learned. And I really hope that we don't just learn, but we take this as an action moving forward, especially here in Uganda, something that we really can do better, and we won't do it better tomorrow, but I think we can start tomorrow to pave the way to do better next month, next year. So 10 years time, we're not part of that third epidemic that Dr. Iddi described. Thank you very much for joining, everybody.